Assalamu alaikum. Today I'm going to share a case of a combined phacoemulsification with the removal of silicone oil. This was a patient who had undergone a pars planovertectomy with injection of silicone oil and now he has developed a cataract. I will first proceed to do phacoemulsification and then removal of silicone oil. There are some important points to highlight in this case. After making the main incision, I inject xylocaine with adrenaline to dilate the pupil. The pupil is mid dilated, and after injecting some viscoelastic and doing some viscomydriasis, the pupil becomes sufficiently dilated. In this case, I have to make sure that the rhexis is adequately sized and it covers the optic by 1 millimeter so that the IOL does not move forward and cause optic capture during removal of the silicone oil. You can see the silicone oil floating in the posterior segment. I make a mental picture of the size of the rhexis and use the bent needle cystotome to make a continuous curvilinear capsulorhexis. And now here I am done. Now I decompress the anterior chamber, proceed to do some hydro dissection, and the nucleus in this case was soft of grade 2 nuclear sclerosis. I used the flip technique to flip one of the poles of the nucleus out of the capsular bag, and I inject some viscoelastic to protect the central endothelium because I might use the phaco probe a little bit anteriorly. However, I try to keep it in the iris plane. Now engage the nucleus, one of the nucleus with the phaco probe and take the chopper behind it and divide it into two heminuclei. The rest of the steps of the phaco were routine. And as you can see, after removing the last sheet of cortical matter, you can see the posterior capsule in silicone filled eyes changes its morphology. It is generally thicker, tougher, and less prone to rupture. There is a central plaque of fibrosis, and now I'm cleaning up the capsular bag. Inject a foldable single piece hydrophobic IOL in the capsular bag, and I am pleased to note the rhexis size is adequate and it is covering the optic 360 degrees. Now in this case it would have been better to perform the chamber with viscoelastic and apply a suture to the main wound before inserting the trocars and the cannula. However, I decided to hydrate the wounds, and after inserting two trocar and cannula, the iris did not prolapse. However, in this case, after I tried to insert the final trocar, it pushed the iris out of the main wound. So it was a valuable lesson for me that even if you are satisfied with your wound construction, you should always apply a stitch to avoid iatrogenic damage to the iris tissue. Now because the cannula was blunt, I tried to make a two-step sclerostomy. However, I was not really successful. Now I'm removing the silicone oil. However, as you will see, my view will start to become cloudy, and you will know here. When I try to focus the posterior pole, my view is becoming hazy. So now realize that this is due to the fibrous posterior plaque which is blocking my view. So I take a 23 gauge vitrectomy cutter and decide to do a primary capsulotomy so that I can more easily view the removal of the silicone oil. So here I will engage the posterior capsule. Now I'm switching to the cutter mode using my foot pedal, and you will note here that because the capsule was very tough, I was not afraid of the dislocation of the IOL. So I'm gently trimming the, the thick plaque in the central region to make an adequate size capsulotomy. It greatly improves your surgical view. So the two things that I learned from this case were that you should stitch the main incision if you do a combined procedure, and secondly, if there is a posterior fibrotic plaque in a case of phaco and removal of silicone oil, you can do a primary capsulotomy using a cutter through the pars plana, and that will greatly improve your surgical view. Jazakallah, thank you for watching. Please comment and give suggestions. Jazakallah.